emergency. So the talk, as was mentioned, is endovascular treatment of basilar artery occlusion by manual aspiration thrombectomy. Basically, as we all know, basilar artery occlusion is a pretty dismal condition for a patient to experience. Comprises about 20% of all posterior circulation strokes, and the stroke subtype tends to have the highest mortality. Both IV TPA as well as IA TPA thrombolytic therapy have altered the natural history of this condition, and clinical outcomes still remain fairly poor. Regardless of treatment, recanalization has been shown to be the greatest predictor of good clinical outcome, and the likelihood of a good clinical outcome in unrecanalized patients is less than 10%. So the need to explore more innovative therapies and how to deal with basilar artery occlusion is warranted. The methods that we employed were basically, we looked at our patients that came in essentially basilar artery occlusions between September 2008 and December 2009. They were treated with intra-arterial TPA as well as mechanical thrombectomy with the Mercy clot retrieval device. And basically, if successful recanalization is defined as a TIMI grade of 2 or greater, was not achieved after up to 2 passes of the Mercy, then manual syringe aspiration through a large bore catheter was utilized. So here is baseline patient characteristics. Just to highlight, the median age was 62 in this cohort of 11 patients. They were predominantly male, predominantly had hypertension. And if you look at the baseline NIH stroke scale was 18 with a fairly wide range from 4 to 32. And the median time of recanalization was 12.6 hours. So all endovascular interventions were using this method of manual aspiration thrombectomy resulted in successful recanalization. Almost half of the cases were rated as TIMI-3, TICI-3 grade. And as far as the actual large bore catheters that were utilized, in 9 of the 11 cases, a 4.3 French catheter was used, in 1 of the 11 cases of 5.2, and 1 of the 11 cases of 5.4. So the median time from symptom onset to recanalization was 12.6 hours, and treatment time, which was defined as time from point puncture to the final angiographic run, was 111 minutes. In terms of concomitant thrombolytic therapy, 3 of the patients received IV TPA, and 9 of the patients received intra-arterial thrombolytic. 3 patients achieved a 3-month MRS of 2 or less, and almost half of the remaining patients, half of the overall patients achieved an MRS of 3. Mortality occurred in 1 patient who did experience a PCA perforation of the cystic thrombus in the left V2, and this resulted in symptomatic bleeding. So just to kind of illustrate the method as best we can, I just want to present 2 cases. First involves a 67-year-old gentleman with no significant past medical history, presenting with fluctuating hemiparesis and dysarthria. He was taken for a CTA, which did confirm evidence of basilar artery occlusion, and then was taken to the angio suite after his fluctuating symptoms had again declined again at the age of 15. So looking at the leftmost image, it shows the left vertebral artery injection, showing high-grade stenosis at the origin, as well as concomitant mid-basilar occlusion. Basically, the high-grade stenosis was dealt with angioplasty, and then a penumbra aspiration catheter was advanced into the proximal pod interface. And this was actually, I think, the first case in which we tried to use penumbra at our institution in basilar artery patient. So 10 minutes of suction aspiration resulted in no flow, and then the decision was made to use a 4.3 French DAC in advance of the proximal pod. So, just wanted to point out the DAC right was advanced over an 18L microcatheter. And I should say that the system is really a triaxial system where they use the 18L microcatheter as well as a guide wire and the large bore catheter, and then the micro catheter, the guide wire removed, and continuous suction is employed. As you can see in the second image, another injection shows complete recanalization of the basilar artery after 2 attempts at manual suction. And then at the end, obviously, it's 3 fragmented clots collected with catheter aspirate. In a 3-month follow-up, this patient remained mildly dysarthric with resolving paresis and was able to complete all of her ADLs, and she was scored as an MRS of 2. Second case was a 54-year-old female with a history of seizures who had actually presented with a typical type of staring spell for her, followed by left hemiparesis. Her ED course involved fluctuating level of consciousness as well as hemiparesis. Patient through slurred speech. Again, the CTA was pursued, and this did confirm basilar artery occlusion. So on the 2 leftmost images, you have 2 different views of tactobasilar occlusion. And on the right, as illustrated by the blue arrow there, there's a 5.4 French penumbra reperfusion catheter, which had been advanced over an 18L microcatheter and 0.01 accelerated guide wire into the basilar artery and into the left PCA. The run-in that location did confirm the intraluminal location of the microcatheter, and at that point, one pass with the Mercy device was undertaken within the penumbra catheter, and this was immediately followed by manual aspiration. So a large thrombus measuring about 3 to 4 centimeters was recovered in its entirety via this method. And then the final image there shows the post-vascular revascularization injection showing TD3. So this patient at 3 months remained mildly dysarthric with minimal hemiparesis, and again was rated as a score of MRS of 2. So our conclusions are basically we have a small case series here, but it does indicate that manual aspiration thrombectomy performed through a large bore catheter can facilitate successful recanalization with acceptable clinical outcomes in basilar artery occlusion patients. And some of the theoretical advantages of this approach is the rapidity of use because it doesn't involve the need to connect to a pump. It can also allow the procedure to be combined with mechanical thrombectomy by deploying an 18L microcatheter as an emergency retriever, and it can be used both pre or post aspiration. Also, there is some recent evidence that perhaps continuous puncture suction may be associated with reduced flow through the influent vessel, and potentially manual thrombectomy, aspiration thrombectomy could lead to less reliance on thrombolytics, thereby decreasing the incidence of hemorrhage. And with that, I'll take any questions.